Start the recording. Thank you, everybody, and welcome. Just a second, Chris. Let me just mute you so that you don't unmute yourself, and then all of a sudden, we're all muted. Okay.
Thanks, Carolyn. I'm just going to do a quick check to make sure my audio is coming through okay. Carolyn, if you could just give me a thumbs up in the chat box, that would be fab.
Yeah, it's great, and we'll cut this off before recording, so I hear you well.
Excellent. Thank you so much. So good morning, everyone. I'm Chris Roach, and I'm the manager for the Primary Healthcare Integration Network. And this morning, or this afternoon, myself and Rebecca Love, who we'll introduce to you in a second, will talk you through supporting transitions in care and some of the work we do on collaborating between acute, community, and primary care. Now, those of you who haven't encountered my accent beforehand are probably conscious that I'm not from here originally, and I do sound a little bit different. I'm fighting a little bit of man flu today, so I might actually be living the home to hospital to home transitions in real time if this cold doesn't get any better. So if I am talking a wee bit too fast or my words are sounding a bit jarbled because of the cold, please, if someone can just flag me in the IM box, I can see it from where I'm sat and I can keep an eye on it. Okay, so in terms of our presentation today, and to do some introductions first and foremost, as I kind of just alluded to a second ago, I've already introduced myself. Rebecca, do you want to take yourself off mute and just introduce yourself to the group so they can hear your voice?
Yeah, hi everyone. I'm Rebecca Love. I'm a planner for the Primary Healthcare Integration Network, located in Lethbridge, but actually today I'm in Red Deer, so I'm hoping that my audio holds up for the presentation.
Thanks so much, Rebecca. Rebecca is our roving reporter out in the field, I guess, today as well, so seeing the province for all of its wonders. Okay, and as I say, I've already introduced myself, but you can see pictures of our faces, so you can put faces to our names as well. So we want to do something slightly different with Pathway Pearls. We wanted to create a degree of interactivity, and we wanted to get to know a little bit more about you. And I can see some very familiar faces on the call already from people I've connected with in the past, but there's some people I don't know. So this is going to be one of those really unusual meetings where we're going to actively encourage you to grab your phone and connect with us over the course of the session. So if you can grab your phone, or if you're in front of a computer, which most of you are being dialed into Link or Skype, please go to the following web address that's on the screen now, which is www.menti.com. Again, that's www.menti.com. And I'd like you to put in the code 270917. I'll put that in the chat box for you, and I'll repeat it in a second. I'm just going to change screens right now. Excellent, and I see people are already ahead of the game, which is fantastic. So the first question we'd like you to ask, and again, I'm just going to pop it into the chat box so people who are just couldn't quite hear what I was saying can see where we're going. So you go into www.menti.com, and we'd like you to put in the code, which is 270917. Okay, and our very first question is a nice little bit of a warm-up. We're just curious as to where you're actually calling from. Where are you today? So what part of the province are you in? So we've got people voting as we speak right now. South Zone is being majorly represented right now. This is fantastic. And Rebecca, you're not even there to join in the fun. Okay, so I see about half of our attendees have just logged in so far. So again, if you're struggling to get onto the website, you just open up a browser, you type in the code www.menti.com, and then when you get to the landing screen, you put in the code 270917. Again, that's 270917. And I can see that we've had about half of our people on the call just so far who've been able to log on to that. So I'm just going to pause for a second to make sure other people can join so we can just get to know you better. Excellent, we're getting some more representation from across the province. Okay, so I'm going to leave this up for a couple of seconds. If anyone is having any problems accessing the site, if you want to just pop it into the chat box, and we'll just kind of sort it as we go on the fly. I'll just advance to the next question. Hopefully you should see the next question pop up, but some good different representation across the province. Excellent. So our next question is, what type of centre best describes where you work? So where are you based in terms of your work? So you're based in a hospital, the community, which would include primary care, continuing care, emergency departments or urgent care, or somewhere else altogether? We're just curious in terms of what kind of a mix we've got of people on the call for today. And it seems a good balance so far of people who work in hospitals and community. And again, I'll just leave it up for a couple of minutes, just while people are just giving us their information and their input. And again, this is just to help us pitch where we'd like to take our presentation going forward. And we've got one other on the line. Thank you. Okay, I'm seeing more people are getting into Menti, which is good. Okay, so I'm going to move it forward in a couple of seconds. So if you're still trying to work out which of these centers best describes where you work, feel free to choose an option and click submit. I'll be moving the slide forward in a couple of seconds. All right, moving forward in 3, 2, 1. All right, and I'm very conscious with this question. It's great to hear we've actually got some primary care people joining us today. That was unanticipated or unexpected, but absolutely fantastic. We're absolutely delighted to have some of our primary care colleagues here. But what we'd like to know is what your biggest curiosity is about working with primary care. And maybe for my primary care friends, I'm going to ask you to flag about your biggest curiosity working in partnerships with acute care or other parts of the system. So what's your biggest curiosity about partnership working? You should find that it's a free text field, and you should be able to type your text in, and we'll just see your answers in a second. Okay, so transitions between acute and primary care. How can we improve transitions? That's a theme that's already coming up already, noting those particular connections. How do we define roles, and how do we help define roles in the system? Thank you. This is great so far. Thank you very much. Just keep your thoughts coming. Transitions communications between hospitals and primary care offices. Excellent, thank you. Resources available in the community. Okay. I'll leave it up for a couple more seconds. I'm conscious that you might still be typing away on your phone or on your computer, so I'll be moving on in about 10 seconds. So if you type a bit quicker or just send an abbreviated message. And don't forget to click submit if you are typing away what your curiosity is from your point of view. Okay, I'm going to move forward in 5, 4, 3, 2, 1, and how best to access. And how about, I'll leave this question up in the behind the scenes. You guys won't be able to see it on the presentation, but I'll have the content from my point of view here, and I'll keep an eye on that as we go forward through the presentation. Okay. So I'm just moving back to our slide deck. Carolyn, if you can just confirm that we're back in the presentation.
Yeah, looks good.
Perfect, thank you. All right, so in terms of our learning objectives, and we'll leave that question up behind the scenes, so if you're still thinking about what your biggest curiosity is about working in primary care or working in partnership, please leave that up, and we'll try and cover as much of those particular curiosities as we do through the presentation, and if not, we'll try and kind of leave time for questions at the end to talk about some of those pieces. So what our objectives are for today is to talk about in a bit more detail primary healthcare and primary care networks in Alberta, so just having a bit of a conversation with regards to how the systems and the structures are in Alberta that we're currently working in. We'd like to give you an introduction to our primary healthcare integration network and some of the pieces of work we're looking into. We're going to delve into integration and then give a bit more information about integrated care partnerships, which is a really fancy way of saying how do you get all the right people around the table to have the right conversation at the right time. We'll have a conversation around the home to hospital to home transition guidelines work that the integration network is currently leading, but is definitely richer for the support of different people across the province, not in the least the COPD and heart failure work that's preceded us. And then we'll wrap up with our pearls or principles that we would like to recommend before opening it up to questions. And I think it's important to always start these kind of conversations around integration and why integration is important by weaving a story through as we go forward through this conversation. And I'd like to start off by telling you a patient story. So one I'd like to share that was shared with me. So there's a person who I know who has had a situation which was a very, very straightforward situation from a regularity of care point of view, which was someone who was going through labor and delivery, having the birth of their second child. Their second child came a month early and had a few complexities that resulted in admission to an ICU. And there were some complications related to the journey that person had up until that particular point in terms of the connections, even internally within the hospital setting, because A, it was an unexpected admission from the family's point of view, and B, it was a challenging situation for sure in terms of making sure all the different pieces and all the parts of the puzzle internally within the labor and delivery function, which included an ICU, were all connected or maybe not have been in some instances as well. So there's some challenges in terms of the inpatient setting. Then the patient, being the baby and the mom, were discharged home, and in that instance, information from the care visit in the hospital hadn't actually traversed all the way through to the primary care physician in a timely fashion. The follow-up had happened in the community with regards to just following bilirubin levels, and the baby was readmitted back to hospital for phototherapy before being discharged back to the community health nurses. And over that time, there was no continuity between the community healthcare nurses in terms of who was actually seeing the mom and the baby on a regular basis and providing advice on things such as breastfeeding and care. And the mom was getting conflicting information on a day-to-day basis. So already you can see a situation that is fairly routine in the fact that while the birth was a little bit complicated and there was a slight extended stay in the NICU, it was only for a few days. It wasn't a long-term stay in the NICU. It shouldn't really have been as complicated as it was. So it was as close to your routine, in inverted commas, birth story through labor and delivery and out into the community. And yet there was still a lot of complexities caused by different people and different partners who may or may not be working in silos already, not having the right information in front of them from previous parts in the healthcare system, and then the impact that has. The impact that had on the mom and the baby, although the baby wasn't being wasn't getting food and wasn't having food intake from that point of view, and the mom was being given inconsistent advice on a day-to-day basis, which in a situation that was already stressful was becoming heightened in more detail. And the reason this is important, because the baby I'm talking about is my son, and the mom I'm talking about is my wife. And I'm illustrating this story by indicating that even when we work in the healthcare system, we all have stories like this where things that should be simple and straightforward and connected aren't. And it's frustrating to see that. And it's frustrating to see your loved ones having to go through this. So the reason this is important to me and why it's important to all of us is because I'm sure we've all got stories where things haven't gone quite to plan when a patient's transitioned from their home location into hospital, through a healthcare setting, and then back out to home again. So this is why this work is super important from our point of view. At this point, I'd like to just kind of give a bit of a update in terms of primary care and primary healthcare. And primary healthcare is often the patient's first stop in the healthcare system. So in many instances, when a patient's going through a healthcare journey in relation to a particular condition, the primary care physician or the primary care clinic setting is usually the first place that patient would see, unless, of course, it's an emergency situation, and in which case your emergency and urgent care centres might come into place. So primary healthcare is a catch-all term that includes all services in your community that provides the day-to-day support for patients and their families through every stage of life. So we consider them almost like the quarterback of care from that point of view. And we did have a wonderful patient quote from one of our patient stories where we interviewed a patient around the role his primary care physician had in supporting him through some transitions in care. And the quote that he gave was, "My primary care physician is not the specialist in me. So it's the person who's looking after him from his specialty point of view, and he's looking after him as a unique kind of tailor-made solution for that particular patient's needs as they traverse through the system." Primary healthcare isn't just your family doc. It can be a whole bunch of different locations, which we've listed there, so including physicians' offices, community health centres, family care clinics, through the primary care networks, of which we've got some representatives here today, medicentres, walk-in clinics, etc. The list is it's not meant to be exhaustive. It's quite a lot of different services that are accessing primary care. So most people often think that when they hear the words primary healthcare, they think of their family doctor and just the family doctor. We want to make it very, very clear there's a whole cacophony of services that operate behind the scenes. And at this point, we'd just like to pause for a second before we start talking a little bit more in primary care. And we'd like to go back to Menti. So hopefully you've still got your browser window open or you've got your phone in front of you. I'm going to transition back. You don't need to put a new code in unless you've closed it off. So if you just give me a second while I move across. And again, if you can't see the code should be 270917 if you've lost that. So we've got a quiz for you. We'd like to know, before we jump in, currently, so as of today, how many primary care networks are there in the province? So your options are, is there 1, is there 5, is there 41, or is there 62? Okay, so I've seen that 3 people have voted so far. Numbers climbing upwards. Thank you so much, guys. Okay, so I've got 9 votes. There seems to be a runaway leader here of 41, with one person voting 62. I'll just leave it up for a couple more seconds if you want to participate. No one's voted for 1 or 5 at this moment in time. Okay, and the correct answer actually is 41 primary care networks. Originally there was 42 in the province. The 2 PCNs did merge, I believe it was within the last year or so. So now we're down to 41. Excellent. So, are PCNs part of Alberta Health Services? Your options are yes, no, or I don't know. Okay, so there's a bit of a runaway leader, but it's not quite as clear-cut in this question. So we've got some people saying yes, the majority saying no, one person saying they don't know, so hopefully we can clear that up for you right now. So PCNs aren't formally part of Alberta Health Services, so they're not actually within our formal governance structures, although we are linked into them through different structures that are in place from a zonal point of view and from a provincial point of view. And the Primary Healthcare Integration Network is dovetailed directly into those particular structures. So it is one of our misconceptions that we have oftentimes that for our primary healthcare integration network, our approach to care has to be somewhat different because the people we're working with are partners that operate largely outside of the system that the strategic clinical network that we work with operates within. So the answer here is no, but we are directly tied into them. And we're just curious, and hopefully for the people calling in from PCNs, this should be a slam dunk for you guys. But and if you're not from a PCN, do you know which PCNs are in your local area? Do you know who your local PCNs are? Okay, so really good news is that most people know who their PCNs are in their local area. There's a couple of people who are unsure or maybe don't know who those people are. So what we can do maybe towards the end of the presentation in the question and answer session, we'll pop in the chat box how you can find out a bit more information on your local PCN or PCNs as it might be for your particular acute care setting. Okay, and lastly, just for our questions for right now, we're just curious just to get a level set in terms of how familiar you are with working with your PCN. So how many of you are currently working with a PCN with the work you're doing? Okay, so we've emphatically got a couple, it's a bit even Steven so far, a mixture between people saying yes and no. Okay, so we've got some people saying they do work with PCN, some people who say they don't. Okay, so hopefully by the end of this presentation we can help indicate some of the benefits of the integration working, and we can give you some tips and tricks in terms of how to connect with the people in your local area. Thank you very much. All right, so we'll just move back to our presentation. Okay, and at this point I'd like to hand over to Rebecca, who'll take us through the next couple of slides. And Rebecca, I'll drive for you and just tell me when you're ready to advance.
Great, thanks, Chris. Everyone can hear me okay?
Loud and clear.
Awesome, thanks. Yeah, so just to reinforce the Mentimeter questions that we went through and what Chris had previously presented on the previous slide, primary care networks are just one way in which primary health care can be delivered. They're groups of family doctors that work together to design programs and services to meet everyday patient needs. And these groups of patients are providers are actually legal entities that provide the framework for which Alberta Health Services, and family physicians via the Alberta Medical Association collaborate to develop those patient medical homes. So next slide, please, Chris. Just some PCN fun facts. Again, most of these were covered through the Mentimeter questions, but I think that they're just really important to understand some of the nuances with primary care networks within Alberta. So there are currently 41 primary care networks in Alberta across the 5 zones. You can see the distribution on the image there. They're directly funded from Alberta Health and governed by the boards with AHS representatives and their physician corporation members. So that's what Chris was talking about, where we're directly linked in. And the majority of family physicians in Alberta do belong to a PCN, but there are select few that aren't part of a PCN. And not all PCNs look exactly the same, and I put look in air quotes as I'm saying that because they might be organized differently or structured a little bit differently. They can have a variation in size, so some PCNs may have a small number of physicians to some PCNs having over 200 member physicians, and then also, of course, the patients that they provide care to can vary as well. So they can have under 2,000 up to over 100,000. The structure of the PCNs or the way that they're organized might look a little bit different too. So some PCNs might have a central office where they house kind of more administrative staff. They might have an actual central clinic where they provide actual patient care. And then there's also some PCNs that have satellite clinics that are usually part of their member physician clinics. Next slide, please, Chris. Oh, I think I'm handing it back to you, actually, to talk about our Primary Healthcare Integration Network.
Thanks a lot, Rebecca. And yeah, so our Primary Healthcare Integration Network, we were created back in fall of 2017. So we're just celebrating our second anniversary this month. And our goal, or our overall goal, is to keep Albertans in their communities as well as possible on their terms. And we do this through different means. We are one of the SCN family. We're one of the Strategic Clinical Network members of family. We were the 15th of what is currently 16 SCNs, to use the short form for that language. And our goal, or our focus with regards to what we do with our aims, is kind of aligned with many other SCNs, but with a particular focus on the world we're looking at. So we're trying to find and share leading practices to achieve integration across Alberta. And by integration, what we're talking about is connectivity and linkages between different providers. So already noting that we have a variety of different people on this call together this lunchtime, and how do we actually make sure that the people are working with the right partners anchored around the patient's needs as we go forward. We work on collaboratively seeking solutions for integration problems. That would be, how do we tackle and break down some of those barriers, recognizing that, as we've already kind of alluded to, the partners that we have to work with in moving a patient from a home to hospital to home transitions, and using my patient example from earlier, there's multiple different people who report to multiple different organizations who don't actually have a singular overarching governance or accountability structure overseeing it. So there's multiple different people we need to bring together from that point of view. We also accelerate spread and scale of initiatives to make sure we've got system improvements. We look for emerging and promising practices elsewhere in the province, and where there's analogies that can be drawn. So if there's something that's working phenomenally well in the North Zone that is a similar problem that is existing in the South Zone, how do we make connections between those two bodies so people can share the experience and the learning, so we really leverage and we tackle it going forward, recognizing not one size fits all across the province. And then we also work on trying to advance the health neighborhood, which we will be talking about in a couple of slides' time. Our guiding principles, and I think these are fairly standard guiding principles for most people, but this is what overarches everything we do. So everything we do is anchored around the person and family member themselves. We're centered and anchored around that particular approach, and making sure that we're giving that consideration throughout all our work as we're going forward. We're obviously population health oriented, so we are focused on what's happening in communities, and as the strapline suggested, we are responsive to local issues. So we are tied in through the slide that Rebecca shared a short while ago through to the 5 zones, and making sure that we're actually being responsive and respective to the needs of the zones as those needs are being put forward. And there's a whole process that enables us to know where the zones might need support, so we can actually anchor our thinking around that. We absolutely believe in a partnership approach, and that's what we're going to major on in today's presentation in a short while. We'll get into some of the ways we approach partnerships and how we recommend approaching partnerships. So we're not just planning things in isolation and hoping the system will come together. We're very deliberate and conscious about how we plan around the needs of the patient. We've talked about sustainable and scalable solutions, and naturally, because we're an SCN, and like every other SCN, we're grounded in evidence. So everything we do has scientific rigor that runs through it. We have 4 areas of focus, and I won't dwell too long on this because we want to spend more time getting into the nitty-gritty of the detail, but our 4 areas are system foundation for integration, which is basically how do we create the conditions to enable integration to take place. So how do we create, for example, joint shared priorities between primary care and the SCN family, and how do we make sure those teams are on the same page from that point of view? To give an example of one piece of work that might go under that bucket, our 3 operational streams are keeping care in the community, which is obviously very tied closely to that strapline of keeping Albertans in their community as well as possible on their terms. So what we're trying to do is make sure that we have projects and initiatives that have members of the community or parts of the community working collaboratively to help anchor around the patient's needs and to hopefully prevent them having to leave their community to receive the care they have to receive. Now, as I'm sure you can appreciate, the province is very large. There's a wide geographic spread across the province as well, and not everybody has the luxury of living in a large urban centre and the services that are provided out of those large urban centres. So we recognise that in some instances you might need to go and get specialty care from a specialist. So that could be a cardiologist, for example, and in those instances we talk about how do we link into specialist and back, but noting it's not like a relay race where the baton of care is handed from one person to the other. While the patient is still being seen by the specialist, there's also probably primary care concerns that are being managed simultaneously, so we need to make sure there's continuity in the information being shared there, and there's linkages from that point of view. And then also what we're looking at is not just improving access, but in traditional ways such as quality improvement projects, but how do we improve access through things such as reducing the need to even wait for a specialist through peer advice from doctors to doctors, for example. But the key thing we want to cover today is home to hospital to home transitions, which is, as I'm sure you can suggest, and we've been talking about a lot already, is very closely aligned to the COPD and heart failure work. But we're looking at it on a generic basis. We're looking at how do we transition patients from their home location into hospital, and how do we manage that transition in to make it as smooth as possible? How do we co-create and partner between primary care and acute during the acute care phase, recognizing there might be information the family doc, for example, has that would be pertinent to the care of the patient as they transition through hospital, and then how do we set the patient up for a good solid transition? So if we come back to some of our curiosities, there was a lot of those a lot of that language that we're trying to address that came up and loud and clear in your answers that you're providing at that point, and they're the kind of things we're trying to address as best as possible through this piece of work. The idea being that even though there's multiple different providers and different organizations providing care through that journey of home to hospital to home, from a patient's point of view and Albertan's point of view, they just see care provision and they don't see different parts of the system. So our trick is how do we make that system as conjoined and as consistent and as accurate as possible. I'm just going to give a very, very quick overview of this graphic, and if you're looking on a small monitor, this is going to be a bit of an eyesight test, but this is basically indicating, and we've already talked about the patient's medical home, which is anchored around primary care clinics or community care clinics. This is where the patient anchors for their clinical care in the community. And as you can see, the people of Alberta are represented in this area here, and just above the central circle. Working out from there, you've got areas in the health neighbourhood, which would include things like hospitals, primary care networks, home care, transportation, which traverses into the communities aspect, public and community health. So you can see a litany of services that I've already kind of talked about in the patient story I gave earlier. And then we also recognize that the health neighbourhood operates in a healthy community, which has things such as social supports. We have things such as housing, finance, entertainment, spiritual needs, and providing our spiritual needs as well. So what we're trying to do through the integration network is bringing this to life, and what we're trying to do is move to a slightly different approach of having integration being about the people. So rather than it being about the experts or the clinical experts providing advice, it's how do we make the people or the patient a partner in that particular journey. We're looking at the full continuum of care as opposed to treating it as a relay race and just running our stretch as quickly as we possibly can and hope everything goes well for the rest of the race. We're looking at the whole race and making sure that all parts of the system are working together. We're also looking at sustainability. So we're looking at creating a system that will work not just for today but in the future as well. And we're looking at strengthening the system as we go forward. And Rebecca, I think we're going to transition now into the integrated care partnership slides. And as we're just doing that, and just give you the heads up to get yourself off mute, what I would like to stress is, as we're starting to go into this conversation around the home to hospital to home transitions, we were absolutely informed significantly by the work of the COPD and heart failure work, where you've looked at this, albeit on a specific area of focus or a specific clinical area of focus. We're trying to do the same thing writ large. So we're definitely learning and leveraging some of the phenomenal work you guys have already done. So with that scene set, Rebecca, I'll hand over to you and I'll drive for you.
Thanks, Chris. So yeah, as Chris mentioned, how do we move the work forward, really taking that partnership or co-design approach, and how do we look at the relay races as a whole? So integration really is that team sport mentality, and it really, as Chris mentioned, involves adjusting the way that we would approach this work from our traditional ways of doing it, and really establishing and adopting that partnership mentality, kind of away from more that transactional part of it. I'll do my part without looking at the whole race. So it's really hitting at what's in it for we, and it's really not to achieve without partners, of course, who are committed to making that happen, as you know. So especially considering that health ecosystem and that complex landscape in which we work, there isn't really one partner or person or place in the system that has all the answers. And so it's really about moving towards that shared responsibility on how we might address these complex issues. So I'm just going to do like a really quick overview of each one of these C's in the image that you see.
Rebecca, we may have lost you.
In no amount of detail. You're back?
You're back. There you go. Sorry.
Okay, I'll try not to move my head.
Okay.
So yeah, I'll just give a quick overview of each one of these concepts. So Chris, if you just want to advance to the next slide there. So co-defining the problem. So it really starts with co-defining the problem or the issue at hand, especially considering how complex some of these things can be. And it's really about seeking to gain that shared understanding amongst all of the partners in the process and incorporating the perspective of all the people that you're working with. And for me personally, I find that this first step is often the most challenging because it really is an iterative process and you quite often don't get it right the first time. So it can take a lot of time to kind of fully gain that shared understanding of everybody and really getting everybody on the same page. The next slide there, Chris. So committing to collaborate. Really to move the work forward, it is really important that all partners are committed to collaborating on this and approaching the work in the same way. And again, without this, you won't be able to move forward to the next step. And so sometimes it does take efforts to go back to step one and kind of reframing the problem at hand so that all partners are willing and committed to making the work move forward. The next slide, Chris. So co-creating, so another key aspect of that co-design and integrating and partnership mentality is the concept of rapidly iterating solutions that have been co-designed or co-created by all the partners. And it's really having that ability to be flexible and adapt to the changing conditions in the real world by responding to things that are working and that aren't, so that you can just kind of prototype rapidly and be responsive in that way. And the next slide, Chris. So co-delivering actions. So once you've kind of figured out what's working and what's not and found a prototype that might work and is ready for that larger scale implementation, it's again by bringing together those key partners and just being really clear about what resources to kind of have this larger scale implementation and what resources you as a partner can provide. And in order to understand why something is working and maybe why something it's not, it's also important to add in those evaluative parts to really kind of create the story. So being able to understand what's happening in your story as it evolves. And then co-investing. So lastly, really in order to share these gains that you've developed by approaching the work in a partnership mentality, you really want to be able to share your story with the others in a more larger scale implementation. So really being able to co-invest in those gains that you've made and providing the tools to kind of scale and spread the work that you have been able to accomplish.
Thanks very much, Rebecca. So I think the key thing to take away from that particular section there is it's critical to identify all the individual partners that you're going to be working with on a particular problem, thinking about it from the patient's lens, so how the patient's going to transition through the system, and then working out who you need to have around the table to have that conversation. So it's the principle of nothing about me without me. So having that conversation, bringing everyone together, being very deliberate in agreeing what you're tackling, being very deliberate in agreeing how you're approaching it, what you're bringing to the table, and how those relationships and how those roles will work, which again was something else that someone flagged at the start of the conversation. We think by following these 5-step processes, you will get to that particular point of actually having that richness of dialogue from a partnership point of view, but also clarity in terms of your roles and responsibilities in terms of who's doing what, rather than getting to this point of implementation and not really being clear on who's tackling what part of it. So we've been set a priority of enhancing transitions in care for all of Alberta, and what we're looking at is partly that's delivered through the AHS Quality and Safety Outcomes Committee. So it's a signature project for us, much in the same way that the COPD and heart failure work is a signature project for the cardiovascular, the respiratory, SENs, plus support from the integration network. So we're in this journey together, and it's a very, very similar journey we're going through, albeit we're looking at it from a generic point of view as opposed to a disease-specific perspective. So hopefully what you seeing from the content on the slide here, what we're trying to achieve is almost directly aligned with what you guys are doing as well. And in fact, there's natural synergies. So the positive I'd like you to take away is the work you guys have already done. It's the foundation for this work that's now moving forward. And it's enabling us to start thinking about this being just the way we should do things for Albertans, not just those who have COPD and heart failure. How do we expand this to other different specialties? The beautiful thing from your point of view is as we start to roll these guidelines out, it'll become more and more socialized and more aware to people, so you'll have less of the challenges with regards to things not being carried out in the community, for example, or things being challenging between different transitions, because now we're putting a system-wide Alberta lens on it as opposed to just looking at it from one specialty. This just details our hospital to home transitions project and what we're currently trying to do. So we're looking at it from a collaboration point of view. We're looking at trying to get common language around transitions, but mainly what we're looking at this moment in time is minimum specifications for guidelines and measurements to go with that. So what is a good solid transition of care? What is our best practice but good solid transition of care as a patient comes into hospital, goes through hospital and goes home again? And then how do those partners work together? And there's been a whole cacophony of work, which we'll talk about in a couple of slides, that's gone on behind the scenes to get us to the particular point right now of having a version of the guidelines that's going for review and for kind of consensus building in the next couple of weeks. We're also looking at measurements to go along that, and we're looking at helping healthcare professionals understanding what part in the system they can play in moving that transition forward. So we're trying to improve continuity, and we can talk in more detail about this if we have time in the Q&A. But just to flag 3 terms, we talk about continuity in 3 terms: so informational, management, and relational continuity. So we're talking about the flow of information between different providers, which again was the key thing that came out of your transitions kind of curiosities and how information transitions between different people. We're looking at, like any kind of guidelines, we're looking at trying to reduce variability, but we're not talking about standardization. We're not talking about a one-size-fits-all. We recognize that the guidelines will look different in certain locations in the province than others. Some problems exist in urban centres that don't exist in rural centres, and vice versa. So we are looking at that going forward, and ultimately we're driving towards improved patient outcomes, experience and satisfaction. And alongside the guideline what we're doing right now, we're also helping support our patients with materials and toolkits that they can help them move through the transition as well. That's work that's ongoing as we speak. I'll just give you a quick run through of the timeline. So we started our guideline work back in December 2018. We had a design day that Balraj Mann and Jim Graham both were able to attend. We had lots of fun in Leduc pulling together our initial crack at the guidelines, and we pulled our design team together just a couple of weeks after the Christmas break was over. We had 70 members in the particular conversation, as I said, and it wasn't just primary care people or just AHS people. We invited people to try and represent different parts of the system, and connecting from that point of view. The physicians were obviously in the conversation too, so we had everybody in the mix from that perspective. From that point onwards, over the next few months between January, February time of this year and then through till about early May, we were working on producing our first set of the guidelines. And it was our best guess based on 70 people coming together to work on those guidelines. But what we recognized is 70 people can't necessarily represent 4.5 million people across the province. So we needed to do a whole bunch of extended consultations with primary care providers, strategic clinical networks who obviously have the experience like the COPD and heart failure work, the zone PCNs, and also AHS operations as well. We also carried out some additional interviews with primary care providers on some deeper dive questions they wanted to ask us for, because they were really committed to making sure this was the best possible guidelines for Albertans as best as possible, and we've carried those out and those are factored into our learning as we go forward. We are now at the stage where we're just about getting ready to do what's called Modified Delphi panel, and if you've not heard of that, it's a really, really super clever technical way of saying we're trying to get consensus on certain things we're not entirely sure where the guidelines are. So in some instances, the things that are in the guidelines can be evidenced in the literature. We could find things. What we've got left over is things that are probably emerging practices that are so emerging they haven't been published about yet. So we're going through a modified Delphi process to say this is where our gut feeling is. From a consensus point of view, can we agree what should be included or not? And that's our next stage that we'll be going through later this year. And then from that point of view, we're also starting to roll out some of our platforms, such as the Together Health engagement platform. I've already mentioned the patient transitions resources, and we're working on the implementation planning that started a couple of weeks ago. We had a meeting as recently as yesterday talking about how we implement this in partnership with our zonal colleagues and how do we get this rolled out across the province to benefit all Albertans. From our next slide is talking in a bit more detail with regards to primary care and acute care perspectives, and I think what we'd like to say from this point of view, I know that the majority of people in this call are from an acute care perspective, and I used to work in an acute care setting before I came to work in the primary health care integration network, and oftentimes, and we hear about some of the challenges in terms of information flow, and they're bi-directional. So there's challenges if I speak to my primary care colleagues in terms of the timeliness of discharge information or the accuracy of discharge information as it pertains to the patient. Oftentimes the patient has more information than any provider in any part of the system, and we're relying on the patient to be the navigator of that information to take place. So when we had those conversations fairly recently, certainly the key things that really came out from our point of view, which will come as no surprise to you as this project, is it's super important for the family doctor to know their patient has been admitted, and that we have the correct family doctor to be able to notify them that the patient has been admitted. That allows for bi-directional flow of information between primary care and acute care setting pertinent to the reason that patient's been admitted. And then obviously we have challenges, as we've already alluded to, and primary care will talk to us about this, about informational and management continuities when a patient's discharged. So some of the informational ones we've talked about are discharge information not following in a timely fashion, or may not be giving a full picture of the patient, or it might not be clear in terms of what our next steps actions might be for that particular patient. Our guidelines fall into 6 different categories. So this is kind of aligned with the particular journey from home to hospital to home. So at the point of admission, we look at attachment confirmation, so the connection to primary care. We have the transition notifications. We notify that the admission's taken place through to the primary care physician or their team. We start the discharge or transition planning process. There's a whole aspect of provide a discharge summary and what should be included in a good quality discharge summary. Then there's 2 steps in terms of how do we get to follow up in primary care and what's the processes for accessing that, similar to what we have in the COPD and heart failure pathways, and how do we maintain the referral and access to community supports, and who's responsible for that, again coming back to that roles and responsibilities piece we talked about earlier. So what would have been done differently? So let me go back to my patient story that we started on. So let's say the system was all interconnected and interlinked as best as possible. Well, my wife wouldn't have been the person who was conveying the information between different people through the healthcare system. The healthcare system would have had perfect timely information. There may have been some continuity of seeing the same care provider day in, day out as we were post-discharge, so the advice was consistent and could have been tested in a kind of PDSA style concept where something didn't work so we could give something else. And that builds confidence in the patient. That would have led to a much better and a more wellness-focused transition out of hospital for my wife and my son, and would have made that very stressful part of our journey a lot easier for us, for sure. And that could have been made come to life through some very, very simple interventions of making sure the family doctor was connected at the right time because they weren't notified other than through ourselves. And how do we also make sure that the right information is following through at the right time? There's plenty of things that happen well with that transition, please don't get me wrong, but there's things we can do better and that we deserve to do better for our Albertans, including ourselves. So at this point, I believe I'm handing over to Rebecca. Do you want to just bring us home the last few slides, please?
Sure. Yeah, thanks, Chris. Yeah, so as Chris had mentioned, there is a provincial implementation strategy coming forward to support the guidelines, and also those patient transition resources that accompany the home to hospital to home guidelines as well, and then also a measure set that will be coming in the future. Next slide. Yeah, so just some takeaways that we want you to leave with this presentation. And really, for me, I think that we're sitting in a really unique and exciting place. And I'm really excited to see how the work unfolds, because I do think that we are adjusting the way that we are approaching these complex issues and this complex work in which we live in. And so I think that there is a movement towards adopting that partnership mentality and knowing that there's not a one size fits all, and there's also not one player in the game that has all the solutions or the has all the solutions to the problem. We really do have that shared responsibility, and I do believe that we are moving in a movement towards what's in it for we versus what's in it for me. And I think just in any area that you're working in or any work that you tackle, it's important just to be nimble. So quite often, it doesn't make it right the first time, and it is that iterative, continuous process in order to move the work forward. And so, if you need any more information, our Primary Healthcare Integration Network website is listed there, as well as our Together for Health platform that allows you to stay up to date and get involved in any of the information coming forward with the home to hospital to home transitions. And then also any more information on that co-design playbook and how to really approach your work in an integrated care partnership way. You can just email us there and we can send the playbook your way. If Chris doesn't have anything else to add, I think that's all we had planned, and just wanted to thank everyone for their time and attention today and the opportunity to present. Chris, did you want to add anything? I think that's kind of all we had.
No, you had that perfectly, Rebecca. Thank you very much. And just echoing Rebecca's sentiments. And Caroline, maybe we'll hand you back to you for the remaining 12 minutes of the session.
Thank you so much, Chris and Rebecca. I really appreciated that presentation. And I really want to use this time for any discussion or questions that any participants might have. So I'm just going to throw it out to the group. Are there any questions anybody has for Chris or Rebecca, or comments from your experience?
And Caroline, it's Chris. Just as people are thinking, I'm just going to pop in the chat box the way you can find out a bit more information about PCNs. So if you do have curiosity, this website is really super helpful. It's part of the Alberta Medical Association's Program Management Office for PCNs, and it has details with regards to the list of PCNs in Alberta, which breaks it down by zone and zone structures, so you can hopefully find it from that point of view. And also a way you can find a doctor in Alberta, which will in turn help indicate which PCN you might be located in as well. So there's some further information on that website there. In some instances, so in some of our more urban settings, you might have multiple PCNs. So just wanted to flag that to you. You might have multiple PCNs in your catchment area where you might be sending patients to and from. And if you're in if you're talking like a place like Foothills Medical Centre or the University of Alberta Hospital,